Good morning, everyone. I believe everybody's in a time zone where it's morning. If it's not, good afternoon, good evening. I'm Sajid Balsari. I co-direct Crisis Ready with Caroline Bucky and Andrew Schroeder. Andrew's here on the call as well. Really glad to see all of you here. I recognize several of the names in the room, so feel free to raise your hands and then interrupt. This is going to be hopefully an important but technical discussion about measuring mortality in complex emergencies. And it would be wonderful to hear from the rest of you that are also not scheduled on the panel, and we'll make sure we leave time for the discussion. Current events around the world obviously prompt this discussion, but I wanted to zoom back a little bit and provide some context to the developments in measuring mortality in complex emergencies in the last couple of decades, especially during the duration of our careers. Joining me in this discussion are Doctors Daniel Poole, Saeed Rahman, Casey Breen, and Dennis Feehan. I'm going to invite each of them to tell us a little bit about themselves, their work, and ask some specific questions about how they are approaching mortality measurements. Before I do that, just a quick recall of some important studies and methodologies that we've either been engaged in or familiar with where mortality estimation in disasters or post-conflict settings has been addressed. A couple of ways to think through this, right? There is breakdown of civil society, of infrastructure, either from natural disasters or from prolonged conflict. And at the very least, you're going to have normal mechanisms of mortality recording being broken or compromised. At the very least, there might be delays. At the very worst, it's completely disrupted. That is assuming that these systems even existed in the first place, or that they were sufficiently capturing most mortality numbers. And there's wide variation, as certainly this audience knows, around the world. There are, of course, more interesting questions around who are we counting and attribution. What does it mean when you count mortality after either disasters or war? Is it just the direct impact? Is it, the prolonged tail thereafter? And this has been a matter of contention, not in academia, but certainly in the policy realm for a very long time. Professor Les Roberts at Columbia in 2000 had published his landmark study showing 1.7 million deaths in the Congo, which went unchallenged. It resulted in United Nations Security Council resolution asking all foreign countries to leave Congo. The UN asked for $150 million in aid following this study. Les Roberts and colleagues again then published two other papers in 2004 and 2006. In 2004, estimating 98,000 excess deaths in Iraq after the occupation. 2006, these numbers are revised as the occupation continues to about 600,000, with wide confidence intervals, but very large numbers, of course. A lot of academics working on mortality estimation stood by these numbers while the US and UK governments pushed back and refuted them. And a very interesting, there were two sort of interesting developments around this study that those of us working on mortality estimations remember. One is the methodology itself, right? Les had for years been doing these survey-based cluster samplings of, go into conflict-ridden zones, do a two-stage cluster sampling, survey households, look at mortality before and mortality during the survey period, to then estimate excess mortality. And the argument was that excess mortality would capture both direct and indirect deaths. The same methodology is then applied by Caroline Bucky and other colleagues when we did the Hurricane Maria mortality estimation in Puerto Rico, where similarly, the problem there was not that the deaths were not counted. The initial problem was attribution of cost, right? There's a lot of criticism of, oh, the government said only 64 deaths. Well, the government said 64 deaths as attributed to the hurricane, and that's a whole other topic, which I'm hoping we'll get into, which is how do you think about attribution? But when we looked at excess mortality, at that point, the government of Puerto Rico had shut down publishing the mortality data. So it was not possible to calculate excess mortality after a New York Times journalist had estimated about 1,000 excess deaths. So then we applied very similar methodologies to Les Roberts, did a household-based survey, and found about 4,000 excess deaths. What's interesting about that excess deaths is it's not the day off, right? It's not the hurricane then sweep through Puerto Rico and kill 4,000 people. It is this prolonged tale of morbidity and mortality that you see for months after because of the indirect impacts of the hurricane. And then this becomes really controversial as you start examining the long tail of effects from war. When do you start counting? When do you stop counting? And how do you account for these indirect deaths? These are just some of the problems. These wonderful panelists that we have been working on other layers of problems and bringing other methodologies to mortality estimations in complex humanitarian emergencies. So with that background, I invite Casey, Saeed, Daniel, and Dennis to join us. May I first invite Casey to talk about their work, the work that y'all are doing together, Dennis and you. I believe you had a couple of slides, and if you want to walk us through how you're thinking about this. A question for each of you is, the sequence of questions that I would like you to answer is a little bit about yourself, sort of where do you come from? What are the tools, what is the training that you're applying to this? How are you thinking about, why are you interested in measuring mortality? What is the problem you're trying to solve? And then some of the approaches that you have developed or working with. So over to you, Casey.
Great. So thanks so much for that introduction. So that really nicely sets up a study that I want to give you kind of the quick 5-minute lightning version of. Just a little bit about myself and my background. So I'm a postdoctoral scholar at the University of Oxford. I did my PhD in demography at the University of California, Berkeley, where I also did my master's degree in biostatistics. So I'm really interested in kind of the methodological challenges surrounding mortality estimation. So the study that I'm going to be presenting on today, so this is joint with Dennis Vian, who's at UC Berkeley and is a panelist today, and also with Saeed, Rahman, Christina Kay, Yuri Smits, who are all part of Impact Initiatives, which is a very cool NGO that does lots of interesting work in this mortality measurement space, and also Steve Ahuka from the University of Kinshasa. So I'm going to skip why we need more methods for estimating mortality rates in humanitarian crises, because that was already very nicely covered. And I'm just going to jump into the method that I'm working on in this study now. So this method's called the network survival method. And with estimating any death rate, there's kind of two key components. So the first key component, in the numerator, you want some estimate of the number of deaths. And in the denominator, you're going to want some measure of exposure. So this can be person days or person years of exposure. And you put those two things together to estimate a mortality rate. And so the network survival method here, kind of the key insight is that embedded in each person's social network, there's lots of valuable information that can be collected and aggregated up to calculate a death rate. And so for here, let's say, for instance, that this red node is someone that we're surveying. This person can have 10 different connections. Then we're interested in also how many of the people that they're connected to have died in a given time frame. And we take those two pieces of information, the number of total people that they're connected to, and the number of total people that they're connected to who have died, and scale that up into an estimate of a death rate. And so I'm going to skip over a little bit kind of the more formal notation, but basically the idea here is you can run a survey, you can sample lots of people and ask them to report on how many people they know. And picking that's a really important design parameter. So how do you define that network tie? And also how many people they know who have died. And then you combine those two pieces of information to estimate a mortality rate. So we designed a case study in the Democratic Republic of the Congo to test this out. So here we looked at 3 different health zones in Eastern DRC. So this is an area that's characterized by high rates of mortality and some violent conflict. So to kind of imitate as closely as possible a setting where there's, say, for instance, a civil war or some other conflict, so we can't do a classical household survey, we set up a quota sample based in Kalemi town, and we intercepted people when they came from Nyunzu, Nyamba, or Kalemi into Kalemi town. So we did all of our sampling here to try and imitate a setting where there was a humanitarian disaster. So we also, because what we're really interested in is assessing how well this method works, we also compared our estimate against a probabilistic household survey. So we conducted a second reference survey, and this allows us to unpack some of the potential sources of error from different methods, and also from the fact that the people who we're capturing in Kalemi City aren't going to be perfectly representative of the people in the 3 health zones that we're studying. So to try and figure out this question of what social networks do we ask people to report on, there's a lot of things that go into this consideration. So if you ask people about too big a social network, how many people they've ever talked to, they're not going to be able to accurately report. If you ask about too small a social network, you'll get really great reports. So if you ask about siblings, for instance, you'll get really high quality reports, but you'll need to conduct a much larger sample size to get as accurate an estimate. So we went out and we did some formative research here in DRC, where we conducted some focus groups and some individual interviews, and we settled on 2 different types of networks, so immediate neighbors and blood-related kin. So these were the 2 social networks that we asked people to report on in our sample. Data collection was carried out over the course of 4 months, which our partner Reach Initiatives, and we conducted most of the interviews at transit hubs such as markets, ports, taxi station, health clinics, footpaths, etc. So just to give you a brief overview of some of the immediate results that we have from the study. So first, I show here our network results for the kin network, for the neighbor network, and a blended version of both the kin and the neighbor networks. So this is unweighted, so we're not accounting for any of the selection into our sample. Broadly, we suspect that people in our sample who are going into Kalemi City are going to be socioeconomically advantaged and have lower mortality in their social network. Once we start constructing survey weights to account for this, first we do post-stratification weights that just adjust for age and gender composition of our survey. We saw our estimates go up a little bit. And then finally, when we construct inverse probability weights, they use all the possible information that we have in our survey about the socioeconomic composition of both people living in the 3 health zones that we're studying and the people in our survey. We see that we have the highest estimates. So these are our network-based estimates. And you can also see here that the kin estimates and the neighbor estimates align closely. Our best estimate here, we're considering this blended estimate, which is about 0.5 deaths per 10,000 person days. For reference, often a value of 1 up here is considered a humanitarian emergency. So now we take this estimate and we try and put it in context with estimates from our household survey. So our network estimates align closely from both our probability and our non-probability survey. Our estimate of the household mortality rate from our quota sample is slightly higher. And then puzzlingly, our estimate from the probability sample of mortality in people's immediate households is substantially higher. And so trying to unpack a little bit what might be going on, we compared to some external studies. So here we have a study by Jared et al., which Professor Les Roberts at Columbia was a co-author on, which first conducted a surveillance site for 1 year. They monitored mortality, births, deaths in a surveillance area. And then at the end of that 1 year period, they conducted a household survey. And they found that this probabilistic household survey produced substantially higher mortality rates than the surveillance site. And one of their key takeaways is that sometimes in these settings, people might have a propensity or some incentive to over-report deaths if they think that reporting deaths is associated with receiving some type of aid. So one thing that could be going on in our study here is that people who are reporting higher household deaths within their survey when enumerators are coming around door to door expect that they might be getting some type of aid. And it's possible that these network-based estimates, where people aren't reporting about their immediate household, but are reporting about, for instance, their immediate neighbors or their next of kin, are going to actually control for some of that bias. So that's kind of a high-level overview of that study where we developed a new method for estimating mortality death rates in humanitarian emergencies. Of course, we need more systematic evaluations of this method in different settings. And also this method is going to require localized knowledge about social networks, diffusion of info about how people learn about deaths, et cetera. So thanks so much and looking forward to the rest of the panel.
Thank you, Casey. Because Dennis and you have worked together on this, may I invite Dennis to follow and then over to Danielle as we move geographic focus as well. So Dennis, over to you.
Sure. Thank you so much, Sachit and Andrew, for helping to organize this panel. I'm excited to be here. A little bit about myself. I'm a demographer. My undergraduate work was in math, but after I finished college, I did a bunch of different things and got really interested in public health and economic development. And that kind of led me to learn about what demography was and sent me to grad school. I focused in grad school on actually the problem of mortality estimation. So in terms of kind of what brought me to this topic, this was kind of like the original thing that I did in demography, and it was really motivated by the fact that it blew my mind when I learned that we really did not know how many deaths there were in many countries in the world. So my background is not really in crisis or humanitarian emergencies. My background is just in trying to routinely monitor for policy purposes estimated adult death rates in countries that don't have vital registration systems. So as a part of my methodological work on that topic, I started with this approach from demography called the sibling method, which I think Casey kind of quickly alluded to. And my work was trying to kind of expand the sibling method. So to first understand the sibling method as a specific way of asking about a type of network, the network where people are connected if they're siblings, and then to kind of use that idea to expand the sibling network beyond just questions about siblings and instead try to base death rate estimates on questions about other types of networks. So this kind of general idea that you can try to sample people and ask them about others who they're connected to through different kinds of networks has had a lot of applications in different areas. There's mortality estimation, but there's also migration. There's a lot of substantive interest in different populations that are sometimes called hidden. So this would be like groups that are at elevated risk of HIV/AIDS, like men who have sex with men or people who inject drugs. Also victims of human trafficking and other groups that are really tricky to measure traditionally. In some cases, we can use methods where we sample people and ask about others to try and learn about these groups. More generally, any situation where we can't talk to people directly and we'd like to instead learn about other people they're connected to can kind of be understood in this kind of network way. And so I've worked a fair amount on sort of how to do that. If you want to sample people and ask them to tell you about others, there's kind of two different big questions. One is sort of statistical. So like about half my work is sort of trying to understand if we have data that are collected in this way, how can we turn that data into the principled statistical estimate of the quantity that we're interested in? And then the other half of my work is kind of more practical. It's sort of like okay, so if we have this formula, how do we actually collect the data so that the data are, high quality and we can have some confidence in the estimate that it produces? So one question that comes up a lot there, I think Casey alluded to in his talk, was sort of, well, which group of other people should we ask? Should we ask the people we sample to report about? Should we ask them to report about their neighbors, their friends, their acquaintances? And there's kind of interesting trade-offs there. So that's sort of my story. So I'm new to humanitarian mortality estimation, but not new to mortality estimation, I would say.
No, it's Dennis, thank you. It's really incredible as you were talking about sort of the two ends of this problem, right? One is you have a formula, how do you collect the data right, or then the data collected, and then how do you statistically figure this out? So not mortality, but morbidity in war. The Syrian American Medical Society, SAMS, had access to, and this was the first time a digital database of this sort was even possible, just because the world was very digitized by the time the Syrian war began, access to data from about 2 million patient visits in underground hospitals in Syria, right? So statistically, I mean, you can just sort of ballpark that will be statistically robust as long as, you know, we know what to account for and sort of the phases of the war and as populations were moving. But interestingly, all those data were obviously collected in Arabic, but across spreadsheets that were not standardized. So at the end of it, we were looking at over 10,000 Excel sheets.
Wow.
So 10,000 different formats of Excel sheets.
Wow.
2 million rows, and all in Arabic, right? So even if you train pre-NLP, so even if you your machine to go right to left within the column, because you were reading Arabic, you had to then go left to right from column to column, right? So there's just, it becomes so overwhelming to even begin to think about these issues. So thank you for raising sort of both ends of that problem. That brings me to Danielle, because your work is in very unstable environments, and there certainly is little to no records in some of the regions that you're working in. So how are you thinking about mortality estimation? What brings you to this, Danielle?
Thank you so much, and it's really a pleasure to be here with you all. So I'm Danny Poole. I'm a population health scientist with a focus on improving the evidence base for humanitarian decision-making, really across the spectrum of operational response, recovery, as well as accountability. And that's where my interest in mortality in crisis settings comes from. I think I'm going to answer this question about mortality by kind of highlighting the four main concerns I have, or opportunities for work for folks probably on this call. So the first one is that I think, as some of the other panelists have mentioned, there's a little bit of an issue with apples to apples comparison. And this is tightly related to how we present estimates. In particular, the Les Roberts Iraq study with the wide confidence intervals was really uncomfortable for politicians, for the people that were actually using those numbers, right? And so I'm interested in thinking about how we can be transparent about our methods in a way that the people that will actually be making decisions based on our findings can understand them. So that's really point number one, is really this, where the rubber meets the road. How are we going to present sometimes complicated statistical methods and tools and findings to a really broad audience, and even the general community, both affected communities as well as internationally. The second piece that we're working on at the Yale Humanitarian Research Lab is, what do we do with all the missing data? So a lot of the context that we're working in, for example, Sudan, people are not sure what has happened to a loved one. There can be a very high, in a household survey that takes, that's administered after a conflict has ended, a lot of people are not sure what has happened to their loved ones or family members. Some whole families may actually be missing. And so that population won't even be included in a household survey. But really our concern is with the people, when you do the door-to-door households surveys after a crisis where there's been, a lot of the current crises are marked by mass kidnapping and executions that we eventually learn about, but we don't know how to relate those deaths back to the population. There's no way to link those when we go back after the conflict. So something that we're working on at Yale is, how can we capture some of this information in real time? with civilian death registration, for example, is a tool that we're working on developing in particular for Sudan. And this is just similar to how you have community health workers. This would be the capture of deaths in a standardized fashion that is consistent with either an existing vital registration system or could be built into one if one doesn't already exist. Let's see. The third piece is about morbidity. And so mortality is really critical, but also if you think about our focus on what information do we need in this moment operationally, like what can we tell responders or humanitarian agencies that are working how to prioritize resources, we do need to know about morbidity. Are there a lot of trauma cases coming in? Is it mostly burns? The patterns of war can be quite distinct. The types of artillery used, the weapons, the violence that is affecting civilians as well as combatants can be quite specific to each context. And so understanding what the real-time morbidity looks like is really critical for informing operational response as well as accountability, and then also to inform how decision makers are going to go about rebuilding the healthcare system and what types of care might be needed. For example, if you have large numbers of amputees across different age groups. And then the final point that I'll make just quickly is the idea of kind of an exceptionalism for some crises versus others. So again, the Les Roberts study in Iraq, I believe experienced a very high level of scrutiny because of that context, because of the geopolitical space in which that result was presented. That doesn't happen in every crisis, in every conflict. And so thinking about from where we sit in academia at Yale, how do we do work in contexts that are more polarizing, particularly even in the academic community as well as where we're working from in the US, and how do we share that work, and what do we need to do differently for those settings? So thank you.
Danielle, thank you very much for that. I wanted to just going to share my screen very quickly to remind us of a couple of developments that had occurred. So, you talked about civilian death registrations and the VDC, the Violations Documentation Center, for those following the war in Syria, played a really critical role, enough where if you look at this paper by Debbie Guha-Shapir, it was one of the first papers that was based on the VDC records, and that's all we had, right? It was civilians recording deaths, and this was all you could depend on because all formal systems had collapsed, and eventually the VDC was unable to keep up with the deaths as the war progressed. So another qualifier to what you just brought up is also attrition with time. The very data sets that you think may be appropriate at a certain point in time during the disaster is able to better or not so well capture what's happening, right? So if the population is stable and not moving, perhaps the surveys work. For all the reasons, Danielle, that you brought up, if it's a population that's on the move, you're going to miss so many. You're going to miss the missing families. You're going to miss the out-migrated folks, even in disasters, not in war. Puerto Rico, this was an issue. I'm also grateful that you brought up this issue of communicating confidence intervals. It was the same issue with the Hurricane Maria study, where the confidence intervals were so wide that Sherry Fink at the New York Times actually followed up with, did 3,000 people die, right? Her first article supported the study, but then there was another article that came out because of the response in the media. They were like, well, is it 800? Is it 8,000? What does a confidence interval mean, right? And so for a brief blip, people were talking about confidence intervals just as we started talking about, R naught with a pandemic, right? It was in the lay jargon. And so there was an article that follows that says, look, here's what it means. This is where the methodology comes from, etc. So your discomfort with the confidence interval reminds us of the conversations in the group at Harvard as well, where we said, well, if we were to do this before, probably figure one, it may have been differently drawn, right? Because we talked about the midpoint 4,000, but actually had not labeled 800 and 8,000 at the two edges of the confidence interval, right? And to all of us in this room, we know what that bar and the dot means, but the lay public didn't. And then what is our responsibility when we push out figures like that? I want to pause there, and before I move on, want to look at the question that Andrew has asked in the chat. I'm wondering if you might be able to comment a little on the recent controversy around the UN's reclassification of deaths. Between May 6th and May 8th, there was a redefinition of the gender and age balance in the Ministry of Health numbers, given a shift to identified casualties. How do you think we should think about these definitional issues given the geopolitics? So Daniel, maybe invite you to respond to that, and then Dennis and Casey, if they'd like to.
So I think first we have to start by understanding why it's important to have the age and sex distribution, or age and sex or age and gender distribution of these numbers. And it's important for, again, the both operational response right now as well as advocacy, frankly. We know that there are high numbers of, in this particular context, young children and women that are being killed, and that can be evidence that there are a lot of civilian deaths, right? So combatants are typically defined as adult men. And so I think just getting everyone on the same page about why this is so contentious is important, right? Work has been done in other settings too that look at the gender and age breakdown of deaths, in part to suggest the high proportion of civilian deaths, indisputably civilian deaths. I am not familiar with how the reclassification has happened specifically. If you can say a little bit more about that, that would be helpful, how the definition shifted.
Andrew, do you want to chime in?
Yeah, I'm not sure I know all of the details on this, but there was a statement issued by the UN saying that there were unidentified bodies, basically, and that so there's 35,233, something like that, like overall deaths that have been recorded, and they sort of shifted that back to 24,000 or so that were directly linked to an identified body. Now, why that sort of shift happened at that time is not totally understood to me. But then the gender and age classification was then constrained to the identified as opposed to the entire group. And that then changed the calculation of the proportion of the numbers that would be young children or women out of the entire group. And so then this was quickly seized upon as a sort of political, sort of highly controversial political talking point because of the reasons that you just outlined. So how to think about that in terms of, it's happening in real time as well. So the response happens quite quickly and in a highly public way under conditions where there's ongoing international legal, cases that are happening, et cetera. So it just first, there's a methodological question around sort of shifting definitions in the middle of an ongoing conflict, and then how to kind of factor that into thinking about what's the appropriate kind of response to the methodological changes in the politics, and sort of how to sort of contextualize that.
I thank you for clarifying. I'll just do the quick answer to the piece about and then have the other panelists kind of discuss further about what that means for mortality estimates. But one of our colleagues has done 5 weeks in a field hospital in Gaza. And so I understand that it is not possible necessarily to identify age and gender of what is being brought in to these sites. So that is a very obvious explanation for me about why those numbers are different. It's also clear that I don't know if that was presented as the rationale behind this. I don't think it's just a different measurement. So I think transparency about what's being measured is really important. But our colleagues' experience is receiving patients in an emergency department that are being brought in on donkey carts, so piles of pieces of bodies. And so while it might be possible to, of course, to determine death and to proceed with triage, the demographics and stuff are probably not possible for a lot of these because of the significant bombardment and the effects on the population. So I think that makes a lot of sense, actually. But the geopolitics of how to present this change and why it's happening now, I think is quite interesting and probably, yeah, I'll let other panelists comment on that.
Thank you. Dennis Casey, do you want to come in here?
I have a couple. I could just say a couple things. I'm not an expert on how they've reclassified estimating age and gender distributions in the deaths in Gaza, but I will say that that's as somebody who's kind of new to this space, it has been surprising to me that there isn't more focus on age and gender in some studies. I think it's often in demography, my home discipline, that's sort of where we start with almost everything, for better or for worse. And I guess one reason is that there's these really striking regularities and patterns of death rates by age and gender in most places, at least during kind of business as usual, so to speak. And that seems like an interesting sort of topic to try and understand if we don't understand. Perhaps we do, and I'm just not aware, but are there kind of predictable patterns of elevated mortality by age and gender in different situations? Is there some kind of typology of, like, in one type of disaster we tend to see this pattern, in another? So that's interesting to hear a discussion about that. The other thing I'll say is that I think it's so interesting and important to think about how to communicate these estimates to policymakers and to the general public through the media. I don't think I have any easy answers to that, but that's something that comes up in obviously a lot for anybody who does applied statistical work, and it's so important. I mean, I wonder how much sort of the sort of visual tools that the Times actually sometimes uses in its reporting can be helpful in communicating what it means to have an uncertainty interval around an estimate. I mean, that may not be good enough for a policymaker who kind of wants something reduced to one number, but yeah, that's so important to identify that as a topic that's worth pursuing further, I think.
I mean, maybe that's a question back to you, Sachin, around like how so this was like the famous redefinition of the number in the Puerto Rico case, which then in and of itself became a significant media controversy that took off without the confidence interval because people want a very specific number attributed. Like how did that particular like what was the management around that issue of uncertainty?
Yeah. So first, I'll share just what happened and what we had to do, and then maybe zoom out a little bit and respond to what all of you have said. So the study comes out. The newspapers were primed, right, because they had sort of the embargoed article by afternoon. Just looking up key politicians had started to tweet this, but the headlines, I think both in the Times and maybe Washington Post said 4645 people died, right? And they picked sort of the labeled number in figure 1, if you will, and it was the rallying cry than in Puerto Rico as well. So if you remember the media images from then, people wearing T-shirts with 4645 and sort of all banners talked about this. And, that eventually not just this one incident, but it contributes to the series of incidents then leading to the governor resigning. We made a couple of very interesting decisions, which in retrospect, may or may not have done some differently, but we decided to not give television interviews because we felt that those interviews would then end up being about us and the team and the study and sort of completely shift focus away from the mortality numbers. The science might recede because then there would be the drama of sort of who the team was and it would just be distracting. I feel conflicted about that decision now, several years later, but don't regret it. I'm just second guessing the decision. What we did is, however, ensured that we did not enter into any advocacy. We let the numbers speak for itself. So every time reporters pushed us about, do you think the government did blah? Or, do you think that this was a result of state neglect? Or do you think the government was trying to hide the numbers? I think we sort of explained just what had happened. But the messaging in the science was so powerful that we were hoping that we could just lead with the science and then let the human rights advocates and the communities do the advocacy. By doing that, we were able to show academic neutrality, right? Or to demonstrate academic neutrality and saying, look, we don't have a stake in the game other than applying all that science has to bear and the tools that we have access to try and estimate what this mortality was. And that was a very conscious decision with a lot of conversations within the team. We were a large team and there were, students and postdocs and junior faculty and seasoned faculty. And we made sure that we all stuck to the science as strongly as we might have felt about all the advocacy issues raised. And I think that allowed us to not be dragged into political controversy. We were waiting for a tweet from the White House that says, immigrants do hashtag fake study, right? But given that Caroline and I were both from elsewhere and had accents, but that didn't happen, right? That didn't happen, and the pushback was about, oh, is it really that large? And of course, then the George Washington study that was sanctioned by the government came up with very similar numbers, sort of in the 3,000s. So that was, those were useful lessons. I think sort of going back to how do we think about this? Some of the challenges that we have in the current crises in Gaza is the political environment on our campuses as well, right, that Daniel alluded to. And so now not only are you trying to lead with science and ensuring that we stick to the facts and the science for the world, but also trying to create that space within your organization. And a question that I have for colleagues here is, how do you think about the incentives to do this work? So the Puerto Rico study, for example, was funded by an emergency fund from the dean's office, right? Because the timelines for this, you can't apply for an NIH grant to go do a household survey. I mean, think about the recall bias 3 years later, right? But now you're in an environment where the institution may not be aligned with the academic objectives, may or may not. And how do you sort of create this space, not just for this specific disaster, but when there aren't readily available funds available to do this very important scientific work? So Dennis, I see you nodding. I'm going to invite you back into the conversation, and then Casey and Daniel, if you want to chime in.
Yeah, no, I mean, I agree that that's a big challenge, and I wonder if some funder kind of developing a program to help support short-term, rapidly designed efforts to understand crises might be useful. I know the NSF has this sort of rapid grants program that probably even that is not speedy enough to respond to some situations where we'd want to be able to field some kind of mortality survey in a hurry. But I wonder, Gates or Wellcome, or I'm not sure who the logical funder would be, but that certainly does seem like an unmet need. I absolutely agree that NIH is not the kind of timeline that would be helpful here. For the broader incentives, I mean, that's a really fascinating question. Well, I mean, so it obviously affects perhaps our ability to go to our institutions and request funds for some situations. I mean, Gaza being one, certainly. It also kind of affects, I mean, I think it's admirable, Sachit, how you describe your team deciding to stick to the science, and that can be hard to do, I imagine, in the kind of heat of a lot of media attention and a controversial issue about which I'm sure team members had an opinion. So some kind of, I mean, I admire your team for doing that, and I think some way to sort of disciplinary way to have that be the norm is probably a good idea. I'm not sure how to foster that. Maybe so again, I'm sort of new to this crisis and humanitarian emergency space, but is there a professional organization or a kind of, is there a community is there a meeting everybody goes to every year or something like that? Do you see each other regularly? I mean, is there a sense of what it means to be in this field?
It's also the work we're talking about is interdisciplinary, right? So the humanitarian studies groups, of course, are an academic group, and they've sort of, I think, emerged over the last 20 years, and Les Roberts and Jennifer Leaning and Mike McRoyan sort of across the country have these centers that have mushroomed. But then this sort of epi-stats demography intersection in crises is a very niche group that sits at various conferences, right? So
yeah,
I mean, we've been talking about this emergency funding idea for several years now, and I think it's hard to. It hasn't happened yet, right? There is
okay.
But I mean, you can imagine what these conversations look like with donors when you say we need an emergency fund to do a study as opposed to distribute aid, right?
Yeah.
How do you actually see value in that?
Can I ask really quick to Danielle, if you know, like, how has this worked through the Conflict Observatory at Yale around, I think the State Department has actually provided most of the funding around that for the Ukraine investigations, I think for Sudan as well. I don't know if something you could comment on, but.
So in terms of financial support, I think there's a couple different ways that we need support from universities to work on this. And the first being financial. So the Conflict Observatory is funding Ukraine. And the way we've been able to pull that off is because we're using methods that we've developed in other settings and applying them to publicly available data. So we're not doing primary data collection. We are looking for funds and fundraising to do some additional work. But the work we have done was really, and I would say also that it's not neutral to decide which crises you work on and which you don't. There's a decision there that we have to be honest about. And so in October, we thought, well, what can and should we contribute to this? And what would that look like? And it just turned out for our group that we do a lot of remote sensing analysis, and that UNISAT, the UN Satellite Imagery Office, has been publishing damage assessments of every single building in the Gaza Strip. So on our end, this is a secondary data analysis, essentially, that I do think is quite powerful, and that's why we pursued it. But so there's the financial support, and what we have also received rapid response funds from Yale for our Ukraine work early on, and we're continuing to fundraise for Sudan through our institution as well. And then I would say the broader knowledge landscape is really important to consider here. So a lot of folks, including some at Harvard, Sachit, Mary Bassett, and I think Ryan Hart's the last name, and the folks working on Palestine have, and on our team, have faced a lot of challenges in sharing results. Peer review processes that are exceptional, that you can see this when you pull down the PDF of an article and you look at the accepted date versus the date it was online. For example, there's some very open conversations, particularly this week. So Mary Bassett and last name is Reinhardt, have a great article about this in The Nation, but how we are going on tiptoes talking about Gaza, and we are not doing that with other conflicts. And we are applying different scrutiny to research about Gaza. And institutions, and that happens at the individual level and then up through institutions, whether it's how a university might include your work in a news email or something like that, to how it is approached by editors. And I think that that's really important, like this conversation about mortality in general, but these numbers, like which crises you're choosing to work on, will really impact how those numbers can be perceived institutionally by funders, of course, and then just in terms of knowledge production more generally.
With due apologies to Furcow, but not just medicine, but public health is politics at a grand scale, isn't it? We bear such responsibility for the messaging that we put out, the work we do. I really appreciate you reminding us that even our choice to engage or not engage in a particular conflict is political. And then, of course, how it is received. We have a few minutes left. I would like to throw this open to the audience and invite questions, if any, from those that are here.
Yeah, I might make a super quick point just to hop
Please.
in. So I think I think the question about broader incentives is fascinating, and I think there's a lot of room here for collaboration with NGOs that are already working in these spaces. I think a lot of the NGOs that already have ongoing operations have a lot of really valuable on-the-ground knowledge that can often be transferred into, setting up, academic studies that are really valuable. And second, I think that getting funding, for measuring mortality is hard, but getting funding for methodological studies, so trying to advance measurement methods, is even more challenging. And I think those are super important, because I think both that while, communicating uncertainty to policymakers is, a very important topic, there's also a lot of work in kind of unpacking what our uncertainty intervals capture and don't capture, because there's a lot of important sources of uncertainty in these estimates. So those are just a few thoughts.
Thank you, Casey. Just want to open this up to others. As we wait for you to either raise your hand or type in your question, I
have another question if you want. I wrote it in the thing, but
you asked us and Casey about working with impact and challenges and opportunities of introducing new methodologies around mortality calculation into conventional information management systems and agency decision making. And just a little context about this is that there's so much excitement about these new methods that we develop in our academic silos, right? At the pandemic, Andrew, Caroline, and I were involved in applying population mobility metrics, right, from cell phone data, and generating these huge reports to hundreds of government agencies around the world every morning. Nishant would sit up all night, and we would push out these metrics with very, very statistically sophisticated analysis of where people are moving, not moving, right? It was all about lockdown, not lockdown, and with very embarrassing confidence intervals. And at the end of it, the government agencies were just like, dude, this is great. I don't understand any of this. Just tell me lockdown or not to lockdown, right? So over to you.
Yeah, I think that's a great, maybe Casey, Zach, do you want to?
Yeah, so I think there's, kind of a lot going on in that question, which is really interesting. But I guess one thought is that often these NGOs have kind of their established ways of carrying out mortality measurement and also for defining humanitarian emergencies. So some of the metrics that they use, for instance, a mortality rate of over 1 death per 10,000 person days, might be a little bit outdated, and we might need to start kind of thinking or reevaluating these metrics. They also use a doubling of mortality rates, which I think we can probably set a more conservative threshold for establishing humanitarian emergencies. Second, I think they do have a lot of kind of established protocols. For instance, there's a lot of faith placed in retrospective household-based assessments of mortality. And I think those really vary in different contexts. So in India, I think though there's lots of evidence showing that retrospective household mortality surveys aren't very reliable. In Africa, they're slightly more reliable. So I think there's lots of kind of methodological considerations that NGOs really do a nice job engaging with, but that also there's more work for academics to think about.
I'll end here with an example where the converse is also true. When we wanted to estimate the mortality, excess mortality, because of the pandemic in the state of Gujarat in India, where all death registry data were completely locked down, it was the NGOs that filed over 90 FOIAs, RTIs, to get the mortality data, right? This is work that academics couldn't do. And then we applied sort of the standard methodologies that we had developed. But the contribution here was truly the folks on the ground in even getting these data, right? And it takes a community to do this work. We're on the hour. Thank you kindly for this really fascinating conversation, which clearly lends itself to a podcast. Much appreciate everyone participating, and thank you everyone for your work.
Thanks everyone. Really appreciate your time.
Yeah.
Thank you for
Thanks so much,
hosting.
Sachin. Thanks so much,
And we'll be posting this and share the video soon.
Great.
Thank you.
Nice to meet you all. Thank you.